for joining us. Welcome to the Digital Education Suite. I'm Dr. Danielle Becker, Associate Professor at Case Western Reserve University School of Medicine and the Medical Director of Epilepsy at the Metro Health Hospital System. Today's conversation highlights the diagnosis of Lennox-Gastaut syndrome, or LGS, Dravet syndrome, and tuberous sclerosis complex, or TSC, in adult patients. However, if you are looking for useful information on diagnosing across all age ranges, visit the Digital Education Suite and watch the webinar Diagnosing Rare Epilepsies. Let's dive in. Before we begin, a quick disclaimer. I am being compensated by Jazz Pharmaceuticals for this presentation. Jazz Pharmaceuticals has approved this presentation for promotional use. Please note that this presentation is intended only for healthcare professionals and should be viewed in its entirety. And just a little bit about myself. I manage a wide variety of patients with epilepsy in both inpatient and outpatient settings. In 2020, I started an epilepsy program at the Metro Health Hospital System, where I also continue my research on the assessment and management of response to implanted neurostimulation devices in patients with epilepsy. I also founded a specialty pregnancy clinic for patients with epilepsy who are pregnant or planning a pregnancy. I look forward to guiding you through this presentation. I hope you find it helpful. Some individuals may spend years, decades even, without a specific diagnosis of their epilepsies. LGS, Dravet syndrome, and TSC are among those epilepsies where patients may reach adulthood without a diagnosis. An accurate diagnosis can be difficult in these three conditions for a number of reasons. Individuals may have varying symptoms that change over time, and though they have a history of epilepsy, their historical medical records may not be available. In the case of TSC, some individuals may not develop seizures until adolescence or even adulthood. Achieving an accurate diagnosis can make a world of difference for patients with refractory epilepsy. An accurate diagnosis can help connect patients to care targeted specifically to their condition. It can help expectations for patients, caregivers, and their families when planning for the future. For patients who have been looking for answers for years, receiving a diagnosis and having a name for the condition may provide relief. A diagnosis can also connect families and caregivers to the advocacy community, which can provide social support, educational resources, and access to the latest research on their condition. Throughout this presentation, we'll walk through 3 case studies of adult patients who've been transferred to your care. Take note of each patient's symptoms and see if you can diagnose their condition. Our first patient is Trevor. Trevor is a 35-year-old male. Trevor is experiencing a new onset of seizures that include multiple seizure types, partial onset or focal seizures, as well as generalized tonic-clonic seizures. His parents, the primary caregivers, say that there have always been cognitive difficulties and he's always had trouble in school. Trevor's initial diagnosis was autism. Other behavioral disorders include overactivity, impulsiveness, and trouble sleeping. MRI findings show cortical tubers. Physical exam reveals lighter patches of skin on both arms that are at least 5 millimeters in diameter and raised papules on the nose, cheeks, and the chin. The papules are distinguished in a butterfly-shaped pattern and range in color from skin tone to light red. Oral examination reveals multiple dental enamel pits. Let's look more closely at Trevor's symptoms, as Trevor meets a number of the clinical criteria indicative of TSC. TSC affects multiple body systems. A definite diagnosis can be made by identifying 2 major features or 1 major feature and at least 2 minor features. We'll start with epilepsy. Some patients with TSC may develop seizures later in life, in adolescence or adulthood. They may present with more than 1 seizure type, including partial onset seizures, atonic, tonic, clonic, or tonic-clonic seizures. Trevor has late onset epilepsy and multiple seizure types. Beyond epilepsy, there are a number of neurological signs of TSC. Cortical tubers are observed in approximately 80 to 90% of TSC patients and are most frequently detected within the cerebral cortex. They can be observed within white matter migrational abnormalities, also known as radial migration lines. Reviewing Trevor's MRI, you observed cortical tubers. Also present in individuals with TSC are subependymal nodules, or SENs, which are benign growths along the wall of the ependymal lining of the lateral and third ventricles. These can be observed in approximately 80% of TSC patients and detected prenatally or at birth. Subependymal giant cell astrocytomas, or SEGAs, are benign, typically slow-growing tumors. However, they may cause neurologic compromise. These are observed in only 5 to 15% of patients with TSC, often prenatally, at birth, or during childhood or adolescence. Major criteria affecting other body systems include multiple retinal hamartomas in the eyes, at least 2 angiomyolipomas in the renal system, cardiac rhabdomyoma, and lymphangioliomyomatosis, or LAM, in the lungs. It's important to note that while angiomyolipomas and LAM are both major criteria, the combination of both without other features of TSC does not meet the criteria of definitive diagnosis. Notably, there are several signs and symptoms on the skin that fall under the major criteria. They include at least 3 hypomelanotic macules at least 5 millimeters in diameter, which is the most common dermatological manifestation of TSC, appearing in 90 to 98% of patients. These commonly present on the trunk, limbs, and buttocks. You noticed hypomelanotic macules on both of Trevor's arms. Additional criteria include 3 or more angiofibromas, the raised papules you observed on Trevor's nose, cheeks, and chin. 2 or more ungual fibromas and a shagreen patch. With just the major criteria, Trevor's presentation is already pointing to a definitive TSC diagnosis. A diagnosis of TSC can include at least one minor feature. Let's take a look at those. The minor criteria for a TSC diagnosis include confetti skin lesions on arms and legs, 3 or more dental enamel pits, and 2 or more intraoral fibromas. Intraoral fibromas appear more frequently in adults with TSC than in children. Intraoral fibromas may also occur more frequently in individuals with epilepsy taking phenytoin. Remember, upon examination, Trevor had multiple dental enamel pits. Additional minor criteria include retinal achromatic patch, multiple renal cysts, non-renal hamartomas, and sclerotic bone lesions. A TSC diagnosis can be confirmed by identifying a pathogenic mutation in the TSC1 or TSC2 genes. Most patients with TSC can be affected by a range of TSC-associated neuropsychiatric disorders, or TAND. Patients may have behavioral difficulties, including overactivity, impulsivity, sleep difficulties, anxiety, mood swings, severe aggression, and to a lesser extent, depressed mood, self-injury, obsessive behaviors, psychosis, or hallucinations. They may have autism spectrum disorder, attention deficit hyperactivity disorder, anxiety disorder, or depressive disorder. Individuals with TSC have highly variable intellectual ability. Patients may also have a recorded history of academic difficulties. Some of Trevor's symptoms included overactivity, trouble sleeping, and impulsivity. He had a history of academic difficulties and was also diagnosed with autism at a young age. Trevor clearly meets the clinical criteria for a diagnosis of TSC. He presented with 3 of the major and 1 of the minor criteria for a diagnosis, as well as epilepsy, and some TSC-associated neuropsychiatric disorders, TAND. If any of your patients are like Trevor and are exhibiting some of the signs and symptoms of TSC, consider confirming the diagnosis with genetic testing. The TSC symptom leave behind is a useful resource to help identify characteristics of TSC. Contact your neurology account manager, or NAM, for a copy. Let's move on to our next patient, Lee. Lee is a 29-year-old male living in a group residential facility. Lee recently transitioned to the group home after the emergence of behavioral symptoms, primarily hyperactivity and aggressiveness. Lee has a history of daily seizures since childhood, with the age of onset at approximately 13 months. However, he was not diagnosed with any specific epilepsy. He has a history of multiple types of seizures, including generalized tonic-clonic seizures and atonic seizures. His family has reported a change in seizure frequency over the last few months, characterized by a decrease in daytime seizures. Lee was prescribed valproate, which initially decreased the seizure frequency. Clobazam was later added to the regimen, but the adverse events, somnolence in particular, had the family looking for another option. He's also tried a ketogenic diet, which has provided a moderate decrease in seizure frequency. Lee's EEG results did not show slow spike and wave or any other abnormalities, but like many undiagnosed adult patients, the childhood medical records were not available to review. On a physical exam, you notice Lee has a 2-centimeter laceration on his chin. He also has trouble walking. Lee's family has come to you with the hope that you might have a new perspective on his diagnosis. Take a moment and consider the most likely diagnosis for Lee. Lee's symptoms indicate a diagnosis of LGS. In 2019, the REST LGS tool was created to distinguish between LGS and refractory epilepsies. It was designed so that experts and non-experts could use it equally, not just epileptologists. Notably, when the tool was tested, non-expert and expert blinded raters scored similarly when using the REST LGS. Clinical criteria for REST LGS were identified and evaluated based on importance. Major criteria for REST LGS include 2 or more seizure types, seizure onset at 12 years of age or younger, a history of EEGs with generalized slow spike and wave discharges or less than 2.5 Hertz, and cognitive impairment since childhood. Minor criteria include persistent seizures despite trying 2 or more AEDs and a history of vagal nerve stimulation, ketogenic diet, or epilepsy surgery. Additionally, there may be evidence of seizure-related helmet use or injuries to the head or face, and a history of other EEG abnormalities. Lee's symptoms are characteristic of an LGS diagnosis. Lee has a history of epilepsy from childhood. He experiences multiple seizure types, including generalized tonic-clonic and atonic seizures, despite trying multiple AEDs and a ketogenic diet. He has also had cognitive impairment from a young age. The laceration on his chin is indicative of drop attacks, which can increase in adulthood. You don't have Lee's childhood EEG history, but a lack of slow spike and wave complexes in adults with LGS is not uncommon. His change in behavior, the hyperactivity and aggressiveness, is also indicative of an LGS diagnosis. You can learn more about REST LGS by using the QR code at the bottom of the screen. For a deeper dive into LGS diagnosing, watch the LGS Talks presentation available in the Digital Education Suite. LGS Talks is a 3-part series featuring the creators of REST LGS. They discuss how they came to work together and how they developed the criteria to expand on the classic diagnostic triad for LGS, to empower experts and non-experts to identify patients who require further evaluation for LGS. We'll move on to our final case, Darla. Darla, our last patient, is a 19-year-old female. Her first seizure was a generalized tonic-clonic seizure just before she turned 1 year old. Cognitive deficits became apparent shortly after seizure onset. Her seizures have evolved over time and primarily include generalized tonic and tonic-clonic seizures. As a child, her seizures were associated with fever, but that has not been the case as she's grown older. Darla has tried a variety of AEDs with varying degrees of success. Some AEDs, specifically those with sodium channel agents, exacerbate her seizures. She is currently on a ketogenic diet, which has helped reduce some of her seizures. A physical exam reveals that Darla has crouched gait, hypotonia, incoordination, and impaired dexterity. Considering these signs and symptoms, what might Darla's diagnosis be? Darla's symptoms are characteristic of a Dravet syndrome diagnosis. Adults with Dravet syndrome can experience persistent seizures, including focal and/or generalized convulsive seizures, which can include myoclonic, focal, and tonic seizures, as well as atypical absences. In childhood, seizures may be triggered by hyperthermia, but this may become less problematic in adolescence or adulthood. In patients with Dravet syndrome, seizures may be exacerbated by sodium channel agents. Darla's history indicates that this is the case for her. Individuals with Dravet syndrome also have intellectual disability, which is typically evident between the ages of 18 and 60 months and occurs after the onset of seizures. Darla's cognitive impairment began shortly before she turned 1, after her first seizure. A neurological exam may reveal some abnormalities, including crouched gait, hypotonia, incoordination, and impaired dexterity. In adulthood, patients may also exhibit a progression of Parkinsonian symptoms, including bradykinesia, rigidity, and Parkinsonian gait. The resting tremor, which is hallmark of Parkinson's disease, is absent in individuals with Dravet syndrome. Darla is exhibiting crouched gait, hypotonia, incoordination, and impaired dexterity. MRIs are typically normal, but can show mild generalized atrophy and/or hippocampal sclerosis. EEGs can show a diffuse background slowing, often with multifocal and/or generalized interictal discharges. A photoparoxysmal response may also be seen. With all this in mind, Darla meets a number of clinical criteria for a diagnosis of Dravet syndrome. With your help, Trevor, Lee, and Darla received a specific and accurate diagnosis. After years of searching, these patients and their families finally have answers and a new path to treatment. Trevor is seeing some improvement in his TSC-related seizures. His parents are also considering surgery to remove some of the cortical tubers in his brain. With a medication specifically indicated for LGS, Lee is finally seeing a reduction in his daily seizures. His parents notice that his behavior is leveling out. A diagnosis for Lee's family allowed them to connect with the LGS community and advocacy organizations. They've become active, providing support, resources, and information for other caregivers who care for adults who have LGS. Darla is now taking a medication with a different mechanism of action, one that does not exacerbate her Dravet syndrome symptoms. So far, it seems to be reducing her seizures. For these 3 hypothetical patients, and for those adult patients you may see in your practice, an accurate diagnosis can make all the difference. If a patient is displaying any of the symptoms we've discussed in this presentation, consider evaluating them for LGS, Dravet syndrome, or TSC. We hope you found the information in this presentation helpful. For more information and to answer any of your questions, your neurology account manager is a great resource. Be sure to reach out to them. Thanks for watching. Continue exploring the Digital Education Suite to expand your knowledge with more educational presentations.